Good afternoon, ladies, gentlemen, and welcome to this session on basically people user, person user experience, and I'd like to welcome you all. A couple of things, a couple of bits of housekeeping before we start. Could you please ensure that your mobile phones are turned to silent? Please feel free to tweet, take photographs of slides and all that sort of stuff, but please keep them on silent. And if there is an emergency, then an announcement will be made asking delegates, exhibitors and organisers to leave the building at the nearest available exit. The muster point is on the, I thought it said pizza then, it's on the piazza outside the Jury's Inn. Delegates with access requirements will be guided to the nearest refuge point by a venue steward, and they'll receive further assistance from there, and no one is to return to the building until official announcements have been made by ACC Liverpool. Right then, we have a fabulous array of speakers for you. My name is Ian Leach. I am Community Engagement and Supportive Care Manager at St Giles Hospice. For 10 years, I was a member of the People in Partnership Forum, firstly with National Council for Palliative Care and latterly with Hospice UK, and I was in the last couple of years the vice chairman of the People in Partnership group, and I finished in September. This is my last gig as a People in Partnership person. And People in Partnership is a great forum to be part of. I would say if you know of people who have personal experience of caring for a loved one, supporting a loved one, and they want to do something, they want to effect change, then the People in Partnership Forum is a great place to do that. I made a phone call to them over 10 years ago now, following the death of my daughter, and that phone call changed my life. It gave me purpose. It helped me to come to terms with a lot of things. It took me to places and out of my comfort zone, to places like I would never have dreamed of. It's probably the reason why I'm sat here now in front of you chairing this session. So, you know, as well as your local sort of people champions, there is a place for national people champions as well. So I just thought I'd get that in. So, our first speaker. We're going to have the 4 sessions of speakers, and then we're going to take questions after that, providing that none of them go on too long. But I will be there to keep them up to time. I hope you've been around all the stalls this afternoon. Remember, it's a great place. If you've got somebody in your office who you don't like and you're liable to get a Secret Santa and you don't want to spend money on them, then you know, there's plenty of gifts out there in those stalls which you can pick up for free. Notebooks, pens, you name it. And they will restock tomorrow as well, so if you're here for a couple of days, you'll be fine. Don't worry if you see the notebooks and the pens going down. So our first speaker, I was her vice, and some say I probably still am. Our first speaker is Lesley Goodburn. Lesley is a campaigner for compassionate care at end of life following the death of her husband Seth from pancreatic cancer. Lesley shared Seth's and her story via a play, a film, and an educational resource called Homeward Bound, which is available to download from the Hospice UK website. She's been involved in education and quality improvements, activities in palliative and end-of-life care. Lesley is chair of Hospice UK's People in Partnership Forum and works for NHS Improvement and NHS England as Senior Improvement Manager of Patient Experience. Her Twitter handle is @LGoodBU. And she can often be found posting pictures of her legs on Instagram and Facebook. And in fact, on my paper underneath here, I wrote earlier mustard because I was trying to guess the colour of her tights. But I think I got it wrong. So please, ladies and gentlemen, put your hands together for Lesley Goodburn.
Hello, everybody. Ignore Ian's summary of my activities. It's only on Facebook, so unless you're a friend, you won't see it. I'm going to talk to you about my lived experience of end-of-life care. I'm chair of the People in Partnership group, as Ian said, which is a group of people with life-limiting illnesses and experience of end-of-life care who work with Hospice UK to develop programmes of work. So I'm going to look at involving people from two different aspects, two different lenses, from the personal experience of end-of-life care and also from the professional role that I do in patient experience, from a hospital and a hospice point of view, and from a carer and a person who's dying point of view. So I'm just going to start with a little film that doesn't seem to have any audio. It's okay, Ian, that was intentional. So, I'm just going to tell you a little bit about Seth and what happened. It was spring 2014, life was great. The snowdrops had broken through the ground, we were in a loving relationship. It was coming up to both our 50th birthdays, our 10th wedding anniversary, and we'd arranged to go on a celebration trip of a lifetime to China to do the Great Wall, see the pandas at Chengdu, and to see the Terracotta Army. We had lots of plans for the future. Seth had been unwell for a couple of weeks, had gone to and fro to the GP. One night after work, feeling really, really poorly, he went to the GP for an emergency appointment, was admitted to A&E, and then the next day, after a scan, was told he'd got terminal pancreatic cancer, late stage, with days, maybe weeks to live. And as you might imagine, our world turned very dark and black. We were thrust into a world of end-of-life and palliative care that we certainly didn't want to be in. That's me and Seth. So the world for us shrunk back from the world being our oyster to conversations about Seth wanting to die at home in familiar circumstances in the comfort of his own home. But very quickly the disease progressed. Seth was admitted to a hospital ward. It was quite stark, it was quite clinical, it wasn't very friendly. And there were lots and lots of clinicians who wanted to intervene in the illness, who didn't necessarily listen to what Seth wanted and what was important to him, but were very much fixated with intervening, trying to manage symptoms, trying to do something else that would give him a little more time. But Seth, unfortunately, died 33 days after diagnosis, and as you might imagine, the world turned very, very black. So 6 months after Seth died, I got his medical records, sat in a room for a week with the medical records, and through clouds of tears wrote down what happened on each of those 33 days. Found myself writing letters to various different roles, oncologists, surgeons, nurses, explaining what it felt like to be me and Seth, me and Seth, on some days throughout that journey. Those were shared with the commissioners and the providers with the idea that we would all sit down together, me as the wife of someone who died, the commissioner and the provider, to change things and to move forward. However, 8 months after sharing those letters with the commissioners and the providers, no one came back to me and nothing changed. So not only did Seth get a terminal diagnosis and the world turned black, not only did he die in a hospital where he didn't want to be and the world turned black, the one thing that gave me hope was that we could share the story and improve things. And actually, yet again, the world turned black because no one listened. I came into contact through that journey with the National Council for Palliative Care and, as Ian has explained, worked with the National Council for Palliative Care to develop Homeward Bound Seth's story, which has been shared. So that's my personal experience of end-of-life care. I'm going to take you through a quick romp through something called the Patient Experience Improvement Framework. And this is something I use in a professional capacity supporting acute community and mental health trusts. So patient experience, the sum of all interactions shaped by an organisation's culture that influence patients' perceptions across a continuum of care. Improvement being the combined and unceasing efforts of people to improve things and make changes that affect patients. And the framework itself is an organisational development tool, it's an opportunity to learn, it's an opportunity for acute mental health ambulance organisations to really do a self-assessment around where they are for patient experience. It's not mandatory, it's not tick box, and it's not a silver bullet. It's the start of a journey. So it's evidence-based. It was basically someone went through all the outstanding CQC reports for hospitals and all the inadequate, and mapped back the emergent themes, which were around, unsurprisingly, leadership culture, compassionate care, learning from mistakes, and safe staffing levels, which in the framework have got these areas of focus: leadership culture, collecting feedback, analysis and triangulation, learning and reporting. So the idea is that the framework helps organisations to really be honest about where they are in terms of patient experience, to kind of strip back the mystery and be really honest and forthright about how they're going to take that forward. So the evidence from working with that framework for the last 18 months or so is that quality improvement capability is really important. Board reporting and board support, leadership and culture are really important. Giving data to people who can make changes in a format that they can use is really important. And having a board who supports the cultural work going forward is also really important. But the three consistent areas of focus are around leadership, culture and learning. You can collect all the data in the world, you can triangulate it and report it, but unless you work in an organisation that shows leadership, shows a culture of learning, then there isn't really much point in collecting the data. So improving patient experience, it isn't pink and fluffy, it's everybody's business and it's fundamental, and that's whether you work in a hospital, a care home, a hospice, social care. So that's what I do as a job. So it's really important to me that I do a job that kind of aligns with the values, the experience of care that Seth and I got. So flipping back to being chair of People in Partnership, a person with lived experience of end-of-life care, how do those things kind of translate to my experience with Seth? Well, the story really transposes that in terms of leadership and culture, actually people weren't listening. People weren't responding to what we wanted. It wasn't personal, family-centred. People were definitely not learning. The opportunity to use that story was given to both commissioners and providers, but nobody took the opportunity to share that story with staff, to use it as a learning opportunity. And the learning opportunity only came about because of sharing the story through the National Council for Palliative Care. So it's all about leadership, it's all about culture, it's about training, it's about the way that staff view the experience of people with lived care. Particularly the area around culture, staff give care that's compassionate, involves patients and carers in decision making, provides good spiritual, emotional support. It felt like we were in a desert, frankly, and that really didn't happen for us. So leadership, culture and learning are absolutely important, and so is data, but actually without those three main things, as I say, you can collect all the data in the world and do nothing with it. So the film at the beginning of the presentation had got a strange noise over it, and it was called The Voice of Experience. So my experience as caring for someone who was dying, who wanted to die at home, was that I was talking and no one was listening. Seth was talking and no one was truly listening. No one was responding. The strange buzzing noise that you heard over the film was the sound of the shredding toilet that was in room 24 in the hospital where Seth was for the last 14 days of his life, the place where he didn't want to be. And anyone with experience of pancreatic cancer might understand that the need to flush the toilet, given that somebody is constantly nauseous and vomiting, the need to flush the toilet is constant and all the time. And every single time I flushed that toilet for 2 minutes and 31 seconds, that was the noise that emanated from that toilet. And if you can imagine over 14 days how many times I flushed it and how many times I asked people to change, to do something about it, the day that Seth died, that toilet was still making that noise. So our voice of experience was that we were talking, but no one was listening. No one was responding with compassion. No one was taking the initiative no one was dealing with the small things that meant a lot to us, because actually at end of life, the small things become the big things, the lens changes.
It was kind of an expectation that there would be someone there to talk to, someone there to help. And although there were lots of people involved in Seth's care, it didn't feel like there was any continuity with those people. So it didn't feel like, from my point of view, supporting Seth, you could actually have an ongoing conversation and relationship with somebody who was there to help you deal with this kind of devastating news and help Seth to deal with what was devastating news, obviously, for him.
So that film was made 6 months after Seth died, around the time that I wrote those letters. And I think the toilet says it all. So from a personal point of view, it's really important that you work with people with lived experience of end-of-life care and people who are dying, that you listen and respond to them throughout that care, and that no one ever is in a place that Seth and I were in where no one was listening, and actually the noise of the toilet drowned everything out, but no one else could hear it because they were all going about their business. And today's presentation is in memory of Seth. Thank you.
Thank you, Lesley. And I think that demonstrates why the voice of people with lived experience is so important and should be heard, not just as a token gesture, but actually heard and really listened to. So our next speaker is Joanna Goodrich. Joanna is from the Point of Care Foundation. Joanna helped create the Point of Care Foundation at the King's Fund 12 years ago. She led the Swartz Round programme and as Head of Evidence and Learning was responsible for ensuring that the Foundation's work is based on best available evidence and research. For some years, she has led training and support for healthcare teams using experience-based co-design, a method which involves patients and staff working together to improve services, now part of the Sweeney programme. Joanna is currently completing her professional doctorate, which explores the impact for healthcare staff when they shadow patients at end of life as part of a programme to improve the experience of care for patients and families. Ladies and gentlemen, please put your hands together for Joanna Goodrich.
Thank you very much, Ian. So, thank you to Lesley as well, because Lesley has told very clearly her story and showed us why this sort of work that I'm going to talk about is so important. So just a quick word about the Point of Care Foundation. We are a foundation now separate from the King's Fund. We have a number of practical evidence-based programmes and interventions which are aiming to improve the experience of patients, but also the experience of healthcare staff. And some of you may be familiar with Swartz Rounds, which that is our biggest programme, but what I'm going to talk to you today is about our patient-centred quality improvement work. So, what is patient-centred quality improvement? We teach the usual quality improvement methods, approaches, techniques, tools, and so on, but we work from the premise that this has to start from the patient's point of view. So unless you understand what is important to patients, you may well waste a lot of effort improving the wrong things. And so we get healthcare staff to use a number of ways to try to understand from the patient's point of view what is important to them. And as Lesley said, it's often the small things that are the big things. One of our first teams was an orthopaedic team, and I'm just going to introduce you to the surgeon who spoke about why he felt this sort of work was so important. He's talking about the care of his mother. His name is Hero, and he led a team now about 5 or 6 years ago.
Her care in my hospital was amazing. She had courtesy, Reliable care, efficient care, expeditious care, safe care, the very best that medicine could offer. And most importantly, she was better. I felt quite proud, actually, that my mother could see how great my hospital was and how great the staff were. 2 months later, I visited her at her house, and I just happened to ask her, "So what did you think of my hospital?" And what she said after this, words can't even describe how I felt. Ashamed, guilty, like I'd betrayed her, probably sums up what I felt. And she said that the 2 days I spent in hospital was the worst experience of my life. I spent 2 days petrified, not knowing what's happening to me, what was about to happen, and as far as she was concerned, she wasn't going to make it out of the hospital and see her grandkids again. How can a mother's son, who is a doctor in the very hospital that she was at, not see the world through her eyes? And if I couldn't see the world through her eyes, it was my mother that I dearly love, then what chance did my patients have whom I didn't know?
So Hero and his team spent time shadowing their patients to try to understand what their experience was like before they started the improvement programme. But the question was, could this approach be used in end-of-life care as well? We have now completed 3 programmes in end-of-life care with cohorts from around the UK of teams, mixed clinical and non-clinical members of staff, all caring for patients at the end of life, but in very different settings. So, for example, in frail older people's wards, in acute hospitals, intensive care teams, cardio teams, dementia teams, community and mental health, nursing homes, drug and alcohol teams in the community. We know there's a need for this, and this slide illustrates it. This was one team's statistics, and so you can see that actually the number of deaths on their ward was actually comparable to the local hospice, and actually they had had either very little or no training in end-of-life care, and this programme was aimed at those people. We know there was a need. We know that people didn't feel confident about talking about end-of-life care. There were national concerns about standard of care at the time. There was a major policy review, which I'm sure you all know about. So the first programme was actually funded by NHS England as part of the end-of-life and palliative strategy. And staff were not only not confident about being able to identify when end of life was approaching, but really what concerned them was they felt very unconfident and ill-prepared to have the conversations with the patients and families about that. So what I'm going to talk to you today about is shadowing, which is one of the ways of understanding what patients' experience is like, along with interviews or focus groups or observations of care. On our other programmes, we get people to take photographs, to observe, sitting in a clinical area. But shadowing is different because staff accompany the patients. They either sit with them if they're in bed, or they follow them. So some of them literally come in on the bus from home with them to appointments. And they're encouraged to shadow at different times of day and night. So the sorts of things that they learn from shadowing are things like this. So practical issues. So they would be talking or accompanying a patient, trying to park their car, coming out again and discovering they had a parking ticket. There was nowhere to rest for the family members. I would have liked a cup of tea. That's a family member talking who'd come from a very long way to visit. The environment, so the side room, they were very grateful for a side room. Another one talked about how the door was wedged open with a bin and slammed shut, and this kept happening. And that there was a lot of noise, outside the room. So typical sorts of outcomes from the project are shown here. So practical issues, so things like a special menu for people at end of life in hospital who were being brought the usual food that everybody else in the hospital was getting and weren't able to eat it, and it was taken away untouched. Call bells didn't have any clips, even though this was a brand new hospital build. So they couldn't reach them because they were falling off the bed all the time. They introduced beds for carers to stay in and remote controls, which was something very important to patients. They weren't able to watch television because the remote controls were always missing. And they monitored the results, so things like nursing documentation, relatives' contact information, medication as needed, prescription. All these things were monitored and improved, and staff confidence also went up. So they used a number of ways to do this. This was just one project in Southampton, so they managed to get a refurbished family room with a bed. They managed to get meals for relatives. This was very important because relatives were saying they didn't want to leave the bedside and go off to find food. So the hospital catering company provided a menu for relatives that was brought to the bedside. And they managed to get the people who provided parking to provide 2 special parking spaces for visiting relatives. And you cannot believe, well, you probably can believe how difficult that was. But they managed it. And the League of Friends are now funding future improvements. So those are practical issues, but there were relational issues as well, and I referred to the conversations about death and dying. So one project at Bath was all about these conversations, and that was what they decided to focus on. So they decided to support the staff and help them to do this. And they managed to monitor it and show that it was improving. And that project is still going now and has moved into the community 5 years later. So improvements for staff include things like teaching sessions for nursing staff, teaching sessions for junior doctors who were very unconfident about end-of-life drug prescribing and in breaking bad news, and medication. Again, this was very patchy, the knowledge was patchy. And they now have end-of-life care facilitators to support ward staff. This is in another project in Worcestershire, where again, they focused on helping the staff have these conversations. So my research project was about looking at, we've seen the impact these projects can have for patients and families, but what about the staff? How do they feel about doing this work? There was another evaluation funded by the health evaluation of these programs, but the acceptability for staff was a question that still remained. So I'm going to tell you very briefly about my findings. Also, what drove me to do this was that we knew from other research that a lot of quality improvement methods and approaches and projects are associated with negative job satisfaction with staff. They don't enjoy it, they don't become particularly engaged. So I wanted to understand the process, what actually happens, what are the practical processes of shadowing, how acceptable is it, what sort of impact does it have on them, and what's the relationship between their knowledge and understanding of patients and their empathy and their motivation to make changes. And we've produced practical guidance for future teams as a result. So this was 19 healthcare teams from across all the different settings that I mentioned, including a CCG and a third sector organisation. These were all telephone or face-to-face interviews and a couple of Skype interviews. So just the headline findings, really, because I've only got a few moments. But they were their attitudes and expectations before they began shadowing. Someone said, oh, I thought I knew what the problems are. I know what I want to change. And so I thought, what's shadowing going to add to what I already know? This was someone who'd worked with patients for about 20 years. Someone else said, I thought it sounded interesting, I'll give it a go. So there was a mix of sort of skepticism, curiosity, but the most prevalent feeling was anxiety, actually, for 3 reasons. They were worried about intruding at a time when there wasn't much time left for patients and their families. And they didn't want to be put in a difficult position themselves either. So they were worried about feeling that they would be unwelcome. I should say that they always asked beforehand and got consent. So they only shadowed people who agreed to be shadowed. How would colleagues feel? So they worried that colleagues would feel they were coming in to watch them or inspect them. They also actually, I haven't put this here, but they also felt that colleagues would think they were not doing proper work. You know, what were they up to, just sitting there when everyone was so busy? And they were also worried about seeing poor care. Someone actually said, I'm afraid of finding out how bad it is. They also had an emotional response to the experience when they did it. So some responded with real anger and frustration to what they saw. And they connected emotionally with families by imagining that it was them and their family and saying, you know, things like, if it was my mum in that bed. They connected with patients. So someone said, I just wanted to scoop her up and take her home. But it stayed with them in a very powerful way. As someone said, it goes into a part of your brain that you remember what you've seen. They all brought something different, of course, to shadowing. So depending on what their role was, or their training, or their personal experience, perhaps of bereavement recently, their personality or their outlook. So some people thought, I won't be able to sit still. I'm a doer. I can't sit still for that long. They had different styles of shadowing. Some tried to be quite mindful about it and get into the zone and imagine they were the patient. Some couldn't help intervening in care. And some took on the role of a companion, and they particularly felt that where people didn't have family and that they were accompanying them and guiding them to appointments or sitting with them. So we've done this many times before, but is shadowing dying patients a particular challenge? And this is what a senior doctor said. It just felt a little bit difficult, though not strained, to be sitting in that space watching what was quite an intimate interaction between the son and the father, clearly the son understanding that his father was dying, you know. It's obviously a very personal, emotional experience. And interestingly, actually, this particular man did thank the doctor for taking an interest in his father's care, once he'd understood why he was there. So empathy and emotion, just a word about this. So empathy is the capacity to understand or experience what the other person is feeling within their frame of reference, to place yourself in another's position. So cognitive empathy is knowledge and understanding, which definitely increased. Affective empathy is the feeling about what the patient might be feeling or the family might be feeling, and that increased. But I'm saying treat it with caution because, for example, there were very strong emotions and feelings about whether a side room or a bay on a ward was a better environment for a patient who was dying. People disagreed on this. And they were saying things like, if it was me, I wouldn't want to be cut off in a side room. It's so dreary, it's so dull. You're forgotten about. Others were saying there's no privacy on a side, on a bay, on a ward. But basically, you know, you'll feel life still going on around you. So before jumping to deciding what to do about this and what improvements to make, it's important to be reflexive, to meet together as a group once you've done the shadowing and to discuss what might be best for the patients and to remember it's not you, you know, it's them. You can't be that person. So very quickly, implications for practice, it does seem to be acceptable to staff once they do it and realise it's not as scary as they thought. It engaged and motivated them to make change. The challenges are more emotional than practical, and this should be recognised and this should be supported, and they should be reflexive so that they can bring about the right changes for patients and families. Once you're there, it makes it personal. And if you want more guidance, practical guidance, and a toolkit on shadowing, it's available at that address. Thank you.
Thank you, Joanna. Again, one of the things I picked up on that as somebody who's been involved in sort of the patient user story is that I always remember when we were caring for my daughter, our care was transferred to Nottingham, and for the first couple of weeks that we were there, we were paying £8 a day for parking, and then we discovered from sitting next to somebody in a waiting room that you could get a monthly ticket for £5 because we were a regular user. And often, you know, people with personal experience, they do see things that that people who are working in an environment don't. Because you're so familiar with it, often you don't pick stuff up, but as I say, people with personal experience often do. Our next speaker is Dr. Clare Smith. I'm going to let Clare tell you all about herself. I know that she she comes from Princess Alice Hospice, and she's talking about what matters to me, a practical example of using shadowing to listen and respond. Clare, over to you. Thank you.
Thank you. Thank you, Joanna, because you've kind of done my introduction to my talk for me. So I'm Clare. I do work in Princess Alice Hospice in Esher, so please don't heckle me, you two down there. I can see you. But I also work in the District General Hospital round the corner, about 20 minutes away, called St Peter's Hospital. And so what I'm going to talk to you about today is using Joanna's shadowing in real life in the DGH with the geriatricians to really look at what happens on our busy, they're called SAMS wards now, because that's what the patients wanted them to be called, Senior Adult Medicine Service wards, and what happens to patients at the end of life to help improve things. So the reason there's two names up there is because the Point of Care Foundation Living Well to the Very End project is all about specialists like us, like probably most of you in the room, enabling generalists, the people that are caring for a lot of people in hospital who approach the end of life, to look at what they're doing and make a change for the better. And so the lead for this project wasn't me, it was Emma Wilkinson. She's actually in that picture. That's some people from Ashwin St Peter's. She's the lady with the red top in the middle. And she's a geriatrician, and she was the kind of driving force behind this project. So we put a bid into the Point of Care Foundation, and we ran this over the last year. And I think this was really driven by two things. And one is that when I walk around the wards in the acute hospital, I can see lots of things that I think we should change, and you wonder which one it should be and what's going to make the most impact. And I'm always thinking what I think, and I haven't really asked anybody else. Well, I might have done, but I probably haven't asked all of my patients. And for Emma, as a geriatrician, people are getting older, they're living longer with more complex comorbidities, and there are unfortunately a lot of people that end up dying in hospital, whether that was their choice or not, or what they wanted or not. It's sometimes unfortunately inevitable. And she had actually heard Lesley's story before, as I have, and felt quite empowered by it to make a change. And so we applied for the funding from the Point of Care Foundation, and we were successful. You don't really need to know this because this is what Joanna's already told you, but this is around, we do lots of quality improvement projects in our hospital, and normally they're born out of the clinician observing a problem or thinking they've observed a problem, probably, maybe, wrongly, thinking they know the answer to the problem as well, and studying it to get to an answer. Whereas this shadowing is totally different to that. It's stripping it back, perhaps having an overall aim, but not going in with any preconceived ideas. which for us as a project group was a little bit weird and tricky. And so we were going to shadow these patients who were dying on our wards, maybe having some idea of what we might find, but not knowing what would be the output of our quality improvement project, because that was the whole point, to look at it kind of bare and learn from it. And there was a big project group. I was hyperventilating actually about watching, sounds silly because I'm a palliative medicine consultant, but asking shadowers to sit and watch somebody who may be very near the end of life, last days or maybe last couple of weeks, waiting perhaps for their fast track to the nursing home, and really just write down anything that they saw or thought or felt. And I'm trying to think why I was hyperventilating about it, and I think it's some of the things that Joanna describes: anxiety about perhaps being in the way, or people wondering what you're doing, or your colleagues wondering what you're doing, although they had it all explained to them. And also, I was worrying about the shadowers. Are they going to be okay? But I think in palliative medicine, maybe not everyone, but I worry quite a lot about things. So what impact is this going to have on the shadowers? Because there were lots of range of shadowers. And actually, most of my fears were not necessary, as is normally the case. So we had some project management support to try and bring it together a bit, and we had geriatricians, a palliative medicine team were involved, and we had kind of ward champions for what we decided to change. And the ward champions were not who we thought they were originally going to be, and you can see the ward clerk on Hollywood, which is the female care of the elderly ward, was the champion for our change on that ward, and one of the HCAs. And we had an executive sponsor, which I think is what Lesley was alluding to at the beginning, that you need some leadership for change. Why am I the only one? Right. So at the beginning of the project, before we started shadowing, we had to come up with some kind of ideals or our aim for change within St Peter's, even if on a small level. So we came up with these 3 things that all our patients and families say about the staff. You listen, you care, and you know me. We understand each other, and I trust you, and I feel at ease around you. And then all the staff say, I listen, I care, and I know you, and we act together for you. So I'm not doing something to you, I'm acting for you. And then this thing in acute trust, everyone's really busy everywhere, aren't they? But there's lots of pressures, so support staff to have time to care compassionately. And Emma was very keen that they didn't have some other box or bit of paper to fill in as a result of our quality improvement change from shadowing. So there are a couple of bits to it. So there was shadowing that Joanna's already described, and this happened on 2 care of the elderly wards, female and male ward. On those wards, at the time this happened, the average number of deaths a month was 15 to 20 across the 2 wards. There's quite a lot of people dying in these hospital wards. And then next to that, we came up with an ideal experience, what we thought would be the ideal experience in the hospital as you're approaching the end of life. And that was drawn on the shadowing experience and also talking to staff on the wards. So the staff members that did the shadowing were a whole range of people. So we didn't, first of all, we worried and we thought, should we just kind of be a bit paternalistic about it and say only senior doctors or nurses should shadow or something like this? And that was probably us worrying about the effect on them. But in the end, what we did was we just kind of, inverted commas, advertised for shadowers. So we let anybody choose if they wanted to shadow this experience, explained it to them in detail before they embarked on it. And most of them were either sitting in the bay next to the patient or in the side room with the patient. And so we had a range of people. We had medical consultants, specialist nurses, heart failure nurse, palliative care nurse. We had people from administration. We had a project manager, junior doctors, psychology student, patient experience coordinator. So a range of different people that might see different things. This slide probably says what I've already said around the shadowing, allowing us to see it really from the eyes of the bedside and the patient and what they were seeing. And we tried to draw it all together in a driver diagram, which is, I think, a project management thing, which enables you to come up with an aim and how you're going to change something and the little things you're going to do. So the shadowers when they went to the ward, so the geriatrician would identify somebody that may be appropriate to shadow. She or one of her team would ask them for their consent, and they'd have a patient information sheet around that. And if the patient was very unwell, the family member would consent. And then in a period of time, the next day or so, one of the shadowers would come to the ward, and they would spend a varying amount of time. So it's not you don't have to do a certain amount of time. It's just whatever you need. Change the word. And so they'd sit there and just observe and fill out this sheet about things they might want to look at, and it gives them some kind of pointers. What time was it? What happened? What were the observations? How did you feel about it? Was there any patient and family feedback? So I just took one of these because they were printed off. So this is anonymous. You can't see the patient's details here, but this was the geriatrician consultant writing. She's sitting there at 11:20 in the morning. Yeah, patient's in bed, legs out of bed, sounds chesty. She's writing what she observed and the themes around what was important there. And then she's written that the cleaner came in the room and didn't really acknowledge anybody in the room. So that's about the interaction with the patient. And the nurse checked the patient, spoke to the shadower before the patient. She noticed that. That might have been because she was the consultant. So that's a little bit tricky, isn't it, to ignore your consultant, perhaps, if they're sitting there. And other things. The clock was very small, difficult to read. So these small things are very, very important. The smells in the room, she thought was nice on that day. So it's just an example of the kind of things they were writing down. And then these are two other examples. So one of them was only shadowing for, I think that's meant to be 250 actually, so they were there for over an hour on that occasion, just watching what was going on, and positive as well as negative. And so, unsurprisingly from what everyone said, the themes around that were clutter. There's lots of clutter on the bedside that you probably don't need, nebulizers that you might not need anymore, urine bottles that you don't need or can't use, noise in the hospital environment, lack of confidentiality and stimulation, and perhaps lack of communication with relatives. And food and drink was inappropriate, was already come up. So I'm going to just skip by this slide, but before this shadowing, the way we'd know where things had gone wrong in the acute hospital is someone would tell us through a day text or a complaint, and we'd see it. And normally the themes were around communication and time, and everyone would say, well, we can't do that because we haven't got enough time, we can't do that because we haven't got enough time. So whatever we were going to use to change it had to be something that didn't really take up that much time. And so we decided our change project wasn't something like the food menu or the bell. It was actually a kind of ethos change for those two wards around this what matters to you concept, which I'm sure you may have already heard of because it's not new. We didn't make it up ourselves. It's born out of a Norwegian nurse who changed the boards on the back of the bed around his patients to less clinical information and more personalised care. And when you ask what matters to you, you're entering into a joint relationship with somebody rather than what is the matter, or can I ask you about that symptom? The balance changes. And I think we're used to that in palliative care. I feel like I'm a lucky person in the acute hospital because I have more time with my patients and I can ask them their top priorities. What are the 3 things that are important to you? But this was about anybody in the 2 wards being able to ask the patient what matters to you. And if you knew that, you were the most important person in that MDT. It didn't matter if you were the consultant or the healthcare assistant. If you knew that, you were valuable because you had a rapport with the patient and they trust our judgment on things. And it helped communication. That's our driver diagram, just showing you that the what matters to me or what matters to you concept kind of drove all the other changes around compassionate communication, attitudes, interaction, and the environment. And so how did they do it on the wards? They just did something fairly simple, which was they launched the what matters to me concept on the ward by the chief nurse. That's the chief nurse in the top right-hand corner, and all the project team going towards and doing some training around it and some basic communication. And the ward teams made these hands to go above each person's bed. And they're updated daily, asking the patient or the family what matters to you. And it could say absolutely anything. So there's a few examples there of what matters to some of the patients on the care of the elderly ward. I like the bottom left one, to get married. So we did have an 80-something-year-old lady get married in the hospital, but I don't think that was hers. And then the middle one actually is for staff, because it wasn't just about patients, it was what matters to you. When you go home at the end of the day, how do you know if you've done a good job? And that's around your personal, your contact with the patient, isn't it? And making it a human contact rather than just a task. So that's the staff one at the bottom, making patients smile, so you see the sparkle in their eyes, which is quite a nice one. And we carry on doing that. Emma blogged about it. She's on Twitter, and she's taken it to various conferences. And there was a prize around if people were doing things that were important to the patient or writing these down, you could nominate them. And so it took off across these two wards. You don't really need to see that, but that's the tool we use to help the HCAs and people more junior in their basic communication with the patient. And we did use lots of measurements, but we were more concentrating on the ethos of changing that. And just small measurements that were easy to see was that the preferred name above the patient's bed was 90% correct after we'd done this, whereas about 70%, 60% before. The hands were always filled out on the day that we audited, and they continue to be filled out today. And in the hospital, we have something called red to green days, where have we done a red day is when you have done nothing useful for this patient to enable them to carry on their journey, as in normally to get out of hospital. And a green day is when something proactive and useful has happened, and we saw more green days than red days with this. So that's the end of my talk about what matters to me at St Peter's. Thank you for listening to me.
Thank you, Claire. Just to let you know that presentations will be available after conference on Hospice UK's website. Abstracts appear in the conference supplement published by the BMJ Supportive and Palliative Care. So all the presentations that you've seen in this session will be available after the conference. So our final speaker, we get two for the price of one here. We get Joe Potts and Deck, yeah. Joe Potts and Kevin Chesters. I'm going to have to let them introduce themselves. The title of their talk is How the Hospice is Working to Embed Patient Experience Throughout the Hospice and Improve Care. I thought as I hadn't got a bio, I'd look on the internet and see what I could find on the internet. And it says that Joe Potts is a racing driver from the 1950s and also a car manufacturer. I don't think that's you, Joe, so I'll let you introduce
kept that
yourself.
quiet.
Thank you.
Thank you. Right, thanks, Ian. Joe and I work at the Douglas Macmillan Hospice in Stoke-on-Trent. It's quite a relatively big hospice, 33 beds. We've got community provision, community nurses and hospice at home, and also day therapy, and also wellbeing services, which I'm the manager of, and that includes social work, admiral nurses, spiritual, religious and pastoral care support, and the counselling and bereavement services as well. So I think probably same for everybody here, you know, we always want to do the best that we can for the people that we work with, and we want them to have the best experience in terms of the care and support that we provide to them. So I think in order to do this, I think we need to be open to continued learning and continued improvement in what we do. And I think we probably all agree, probably the best resource for supporters in doing that is the people that we work with. And this has been at the heart of our thinking for quite some time, and we've spoke for some time about how we embed this in our organisation through every level. And this has led us to have sort of conversations with Lesley in terms of the work that we've done through Dying Matters Awareness Week and how we can move this forward. So one of the things we'd spoke about quite recently in terms of is building upon and probably adapting the work that's been done on the NHSI's Patient Experience Improvement Framework and looking at adapting that into a hospice and possibly an end-of-life care setting as well. So I think we've already sort of looked at in sort of quite some detail about what the improvements framework is about. So it was initially looked at in terms of comparison between those with a CQC rated outstanding rating and inadequate, and looking to comparisons of how those with inadequate and require an improvement can improve the support that they've been providing. And I think it's a multi-level approach to looking at what information we collate across all aspects of service and hospice provision, and using that to help inform and improve that continuous improvement cycle.
And Lesley touched on the key themes that came out of that NHS patient experience framework. So the 5 themes were leadership, organisational culture. So things for us at the hospice was around leadership, having a really visible executive team, but also supporting the managers that are on the ground, making sure that they're skilled to lead their teams. So there was investment in training for us. Organisational culture, are people able to speak about issues? Are they able to approach the chief executive or our freedom to speak up guardian? Compassionate care, obviously, that's something that we would expect to happen within a hospice, but we're not infallible, so there are occasionally times where we need to look at ourselves and was that the best thing that we did for that person or that family? I'm sure some of us can relate to safe staffing issues. It's something that's been a common theme through the conference already today around medical staffing recruitment, so we're not immune from those issues that we see in the NHS. And then consistent incident reporting and learning lessons, which is a real important one. So when incidents happen, they're reported either through Datix or a localised system. How does that get translated into something that the staff can do on the ground, that they can change practice? So I just want you I know you're not all in pairs, but just for about 30 seconds or so, just have a chat to the person next to you, or if you've got someone, if not, just have a think to yourself. Do these 5 key themes translate to issues that we see in the hospice sector at the moment? So just have a 30-second chat to each other. So for me, just looking at those themes, some of them do translate into hospice care, but what we want to do after today is look at developing our own hospice-specific framework for improving patient experience, making sure that we listen to people, making sure that we provide access to multiple formats of feedback. We used the basis of the NHS improvement framework, and it was actually set up, as Lesley said, for acute hospitals. A lot of the things in there we can use to learn from. There are things that we can't access because we're an independent organisation, but there was learning for us. So on our next slide, we've just done a sort of a mini analysis using those 5 key themes of the areas where we got good practice, and then we'll talk to you about the areas for improvement as well.
Yeah, so leadership is one of the sort of key themes and something that's really important, especially I think if we think about what Tracy was saying to us this morning in the current sort of state of hospices now, in terms of 82% experience some financial difficulty. Now, it's multifaceted with the reasons why that might be, but I think in terms of our hospice, I think one of the things we recognise, we were fortunate enough to fall in the 18%, is the sort of leadership, sort of business acumen of our CEO in terms of making the organisation a financially sustainable one. They've recognised the importance of investing in the leadership. So we, as part of the senior leadership group that's been formed, we've all had some enhanced training to support us in developing leadership qualities. We've been looking at involving patient stories and patient involvement at every level in the organisation. So at board level, we've got patients and carers presenting their experiences there. So the strategy that we've done and we're about to launch now has been done in partnership, utilising patient and sort of carer feedback. And again, it's linking into us being a sustainable organisation.
And a really good example of that working with patients is our new Dementia Wellbeing Day that we launched very recently. And before, very initially in those early discussions, we actually learned the model from Northern Ireland Hospice, and they were very pleased to share it with us at their conference earlier in the year. But to adapt our own, we wanted to speak to our own carers and our own users of that group, potentially. So we spoke to them, we developed the 12-week programme for them, and then we're going to assess it along the way with their feedback and with their input. So it's about when we develop new services, which we're very good at doing in hospices, we apply for a pot of money that we feel that will make a real benefit to a certain group of people, and we go and do that piece of work, but we don't always involve them in the actual planning and the actual commissioning of that work. Things around organisational culture. Some of you will have heard of freedom to speak up guardians that was mandated through the NHS, but there's no reason why we can't, as hospices, adopt and have a freedom to speak up guardian or more than one within our organisations, and we chose to do that. Staff surveys, making sure that staff have options to give feedback at regular intervals and that we actually deal with that feedback and help support staff. Things around incident reporting, making sure that we've got good clinical governance structures where data can be fed back and analysed, looking at trends, timely reporting to the CQC. We've got something that's really beneficial to us called an improving care group, and it's the staff on the ground, the healthcare support workers, staff nurses, that feed into a working group that look at key issues within the hospice. So this will potentially be one of the pieces of work that we'd want them to be involved with. And they look at that project from the start to the end. They develop training programs for their peers, all sorts of things. So it's a really good, beneficial piece of work for us. And then again, I've talked about, say, staffing levels, but using sort of national accredited tools. I know there are a couple here at the hospice today that will give you some advice on how to benchmark your staffing against other organisations, making sure that you are using the right amount of staff. When you use bank staff, that they're fully checked, that they're supported, they're inducted. All these things link into patient experience. So if we get these 5 key things right, then we should improve patient experience. But as I said before, we want to make sure that we do one for hospices and end-of-life care services to see if the themes are any different.
All right, so
Okay.
I was just going back on the compassionate. Go on. So in terms of compassionate care, we're embedding a human rights-based approach to delivery of care within the hospice. We've also embedded that in the equality and diversity training. I think one of the key things is in terms of human rights is Article 8, a right to private life, family life, home and correspondence. It's got a much wider interpretation than just the issues around privacy and communication. It's around the sort of physical and mental well-being, but also the key part of it is about choice. So if there's decisions around like the care and treatment, it's about us leading decisions around that. So we often talk about person-centred care, but where we've got people who've got a capacity to make decisions about their care and treatment, I think what we should be framing it as is person-led decision-making. And this isn't just at an individual level, it also is in terms of an organisational and service delivery level. And this is one of the key sort of themes that's strands that feeds through into like a patient experience and involving people who use those services and developing them. Again, we've done this in terms of the Dementia Wellbeing Day that Joe's made reference to, but lots of other projects that we've been involved with as well in terms of care and patient support and developing a team of volunteers that support patients and those caring for them. The advanced care planning in terms of levels of care documents that we did with people who can do some anticipatory care planning on a best interest basis for those people who lack capacity. So we're involving dementia carers as part of that process. And in terms of embedding it through a values-based approach, so we've got our own hospice values of compassion, accountability, respect and excellence, and that's threaded through the organisation through our ongoing performance discussions, our appraisals. Okay, yeah.
Thank you.
So areas for development. So we mentioned a few areas where we're already sort of incorporating the voices of people experience. And so we want to expand on them. We have internal forums, the patient and carer forums, and we want to take those out into the community as well. Also, we've been doing some work and trying to be influenced by the Point of Care Foundation's work, and one of the strands is like the experience-based co-design. We've recently done some work with a charity called Pumping Marvellous in terms of helping to improve like the care and support that's provided with heart failure coming through the pathway from the Royal Stoke University Hospital into like hospice care. And we've done some videos around like breathless management and advanced care planning and trying to lessen anxiety in terms of around where people are thinking about being referred into like end-of-life care. We've also got the questionnaires, so we're generating lots of information, but we're thinking what need to like sort of formalise it into a strategy where it's at the heart of everything we do. Rather than being an add-on, it's at the centre of everything that we do and the starting point of everything that we do.
Just a couple of other points that we talked about was using other methods of collating patient feedback. We've got a really good Facebook page for the hospice, and people leave their feedback, and it's generally all positive. But that doesn't then feed into clinical governance to look at that feedback. So it's really, that's already data that we're collecting, but also making sure that people have got access to be able to provide feedback in multiple ways at multiple different times during their hospice experience. For people that are hard of hearing, making sure that we offer different formats of being able to give feedback, not just paper surveys that people get sent or through the post of the person that's been bereaved. Making sure that, as I said, decisions affecting hospice services will involve users at some point during that process, if not right at the beginning, at least partway through and at the end and when we're evaluating things. We don't exist in isolation as hospices. We've got lots of collaborative partners. A lot of them engaged in the same sort of work that we're doing. So we've had conversations with our local trust in terms of where they're looking at end-of-life issues and how they engage with the people using their services. There's lots of crossover between us, so we're doing some collaborative work around that. And one of the things that we started to look at is actually it's important to look at what our demographics are. Who are the people that we're supporting in our community? So we recently went to an NHS Expo and listened to some representatives from CCGs in Devon and Derby who've looked at setting up citizens panels. So they got some funding from NHS England to do, and they've employed organisations that have looked at the demographics in their area, and then they've gone out and actively recruited people to be part of a panel that is representative of those demographics that they provided, which provides a really useful sort of capture of that actually we were all communicating and talking to the people who we're supporting in our communities, and that's another area that we're taking forward at the moment. Brilliant. And then just to finish on, what we'd like to propose in the near future is development of a hospice network to look at patient experience and perhaps developing a sector-specific assessment tool that we can use in our own organisations to look at what we do really well, help demonstrate evidence to CQC when we get inspected, at what we do to actually capture patient experience information, but also to improve patient experience. If you'd like to be involved, we're hopefully going to have the support of the People in Partnership group to help us develop that tool and other organisations alongside them. If you'd like to be involved initially, if you want to email myself, and then I'll get in touch with you in the near future about how we're going to take that forward. So thank you very much for listening, and we'll see you for the rest of the conference.
Thank you very much, Joe and Kevin. We've got time for a couple of questions, if anybody has any. If we could bring the lights up so I can see. This is that bit where it's a bit like question time and you say the gentleman over there in the white shirt and the blue glasses. Anybody at all with any questions? Yep, the lady in the middle. Have we got a microphone? Or can we get a microphone to you? Or can you shout loudly?
Can we go over to the stand?
Or you can go over to the stand if that's...
Yeah.
Shout, yep.
They were shared with the clinical commissioning group in the hospital. The clinical commissioning group didn't want to meet with the hospital and me, but the hospital were happy to meet with the clinical commissioning group. So it was two separate conversations. They were kind of left with them to do something. No one got back to me 8 months later. Nothing had changed. And in the meantime, I was determined that I would do something to take that forward. So I respectfully asked each of the organisations to return the chronology and the letters to me, which they did, and I kind of sort of forged my own path in terms of sharing the story.
Thank you. Any other questions? Lady down in the front, yep.
There wasn't a prescriptive time. I think that was, so they could, I said it now. Can
I just say the question was how long was the professional shadowing for?
So they didn't have to sit there for 1 hour, 2 hours or anything. They could do it for as long as they were available to, and they could come back at another time. So sometimes 20 minutes, sometimes someone would sit there for an hour. So the shadowers, in total, it was over a few months that we did it. Yeah, so there wasn't like hundreds of shadowers over one day. It was a very surreptitious, gentle kind of, yeah. Yeah, yeah. So when you see, I think it's tricky. I think it was tricky to release ward staff to do it. So the people that you see, the easier people that could agree were people slightly out of the ward. And I think that was easier for them to shadow anyway, because otherwise you're being critical of your colleagues and yourself, or perhaps critical of your colleagues and yourself. But all of them, when we met in the little group, they hadn't freaked out, and they said, some of the non-clinical staff said, I'd do that again, actually. If we did that rolling, I'd do that again, which wasn't what I was expecting. Yeah. Yeah.
And there was the lady in the middle with the hand up. Yep.
I mean, watching you, yeah. Like I wash my hands better when the infection control lady's on the ward. But, no, I don't, Anne. I wash my hands well all the time. But it's interesting, isn't it? But I think people quite quickly forget that you're there, which is the point, isn't it, about some of our patients. And so some of those interactions, you can see that they didn't notice, or they didn't. You can see from what the shadowers wrote down that things weren't suddenly great because they were there. So, yeah, there'll probably be a little bit of that, but there's still enough rich data not data, but observations of things you can change around being with the person more, I think.
Okay, we just got one more question. The lady on the end of the row there.
Oh, okay, yeah. So the actual tool that Lesley referred to earlier is called the Patient Experience Improvement Framework from NHS Improvement, and it was developed for acute hospitals to assess how they analyse patient experience information from everything from complaints to how they actively engage with patients at board level, all through the organisation. And there's probably about, I don't know, Lesley, it's about 40 questions to ask yourselves as an organisation. Yeah, so what we'd like to do from today is develop our own tool that fits better with us as hospices and palliative and end-of-life care services, because we recognise that some of the things in here weren't appropriate for us and we would never be able to achieve. And likewise, there's going to be other things that we would want to achieve as a hospice that aren't recognised in this document. So that was what we would like to propose after today.
And can you just remind of your email?
Yeah, it's Joe Potts, J-O-E, Potts, P-O-T-T-S, at dmhospice.org.uk.
Okay, we've come to the end of the session now, ladies and gentlemen. There's another plenary in here shortly. So thank you very much. I hope that's been useful for you.
Just need to intervene. Sorry to be a pain and to hog you a little bit more. But Ian mentioned that he'd spent 10 years working in the People in Partnership group for the National Council for Palliative Care and for Hospice UK. When Seth first died and I got involved with the National Council for Palliative Care and became part of the People in Partnership group, I was massively admiring of Ian's work, the work that he's done around compassionate employers, around sharing Mel, his daughter's story. So given that he stood down from the People in Partnership group, I just wanted to give him a little something from the group. To say thank you very much.
That's totally unexpected and really kind. And I would just reiterate, the phone call I made in 2009 to what was then National Council for Palliative Care completely changed my life. It gave me a purpose, it gave me a voice. I don't like to use the word fortunate, but my daughter's end-of-life care was really good. and I thought that was average until I sat in rooms and heard people with similar stories to Lesley's, and I realised how good it was. But there is still a voice for the good as well. It's not all about the complaints. It's about the good practice and the things that that people do well. So thank you for this. It's been fantastic being a part of it for 10 years. For those of you who, for this is your one and only day at the conference, have a safe journey home. For those of you who are here till Friday, good luck. Thank you.